Good evening to everybody. First of all, I'd like to thank IPSA for supporting this series of webinars, including this one, for unrestricted grant given to the society. Next. The webinar, as always, will be recorded and will be available in our website in about 1 month time, as all other webinars that we performed in collaboration with IPSA. And also, I'd like to thank our President-elect, Michael Ford, and the chairman of our scientific committee, Paolo Capogrosso, who are working very hard in the preparation of our next Congress, which will be in Vienna next February. The abstract submission is open, so the deadline is October 19, and also Congress registration is open. I'd like to remind you that early bird fee registration deadline is the 21st of October. I'd like also to remind you our educational activity. ESSM School is fully booked this year, but for sure there will be space for next year. We have still some available seats for the EFUS, our other educational activity devoted for the study of ultrasound for the evaluation of female sexual dysfunction. So if you are interested, there will be a face-to-face phase of the course in Budapest. Again, there will be the possibility to have a practical parts in 2 accredited ESSM accredited centers, which are Florence and Naples. Next. Our books, for sure, the book will be available soon, in particular the updated version of our Manual of Sexual Medicine. I'm sure that it will be available in 2025. I'd like also to thank Daniar Osmonov, the chair of Educational Committee, which is responsible for all this webinar. I'd like to thank Daniar, who worked very hard along with his committee to prepare and to guarantee the high scientific quality of all other webinars. So the topic today is sexual dysfunction after pelvic radiation therapy. Next. And we have very, very well-known chairs, such as Elena Colonnello from Rome, Italy, and Harmi Soev from Germany, very, very young, but very well-known expert of the field. Next. We have a fantastic panelist, so Luca Incrocci, a close friend of us, past president of the ISSM, coming from Italy, but living and working in Netherlands, Rotterdam since a long time. Next. And Celeste Manfredi from Naples, again, Italy. Next. So I'd like to remind you that you can use Q&A section to launch some questions, and all the questions will be addressed at the end of both presentations. Next webinar, again with support of IPSA, will be next 12th of November, again at the same time, 8 o'clock in the evening. The topic is myth and reality of the management of Indurational penis plastica. So enjoy the webinar and thank you for joining us. Elena, please.
Good evening, everyone. Thank you, Giovanni, and thank you to the IPSA. It's my pleasure to introduce tonight Professor Luca Incrocci, who we all know for being the past president of the International Society of Sexual Medicine, and is currently Professor of Genitourinary Radiotherapy at the Erasmus Medical Center Cancer Institute in Rotterdam. Tonight, he will speak us about epidemiology and risk factors. Please, Luca.
Good evening, everyone. I'm going to entertain you tonight with this topic on sexual dysfunction after pelvic radiation therapy, looking particularly at the epidemiology and the risk factors. I have nothing to disclose. I will focus particularly in prostate and gynecological cancer. For those who are not familiar with radiotherapy, there are two mechanisms where radiotherapy can cause damage of the DNA and the malignant cells. Not direct action in 2/3 of the cases, where the damage of the DNA has reached through the radicals, and a direct action in 1/3 of the patients where the photon, the radiation beam, directly damage the DNA, causing the death of the malignant cells. A lot have happened since 1895, when Konrad Röntgen realized that using Röntgen therapy might be useful to treat several diseases, but also before that be used to look into organs in the body that were not at that time visible. And we get to now today to very modern machines like the CyberKnife, the MR, Linac, and of course also the products. This is an example of one of the oldest machines in the 60s up to the very modern linear accelerators nowadays. And what is also important to realize is that not all tumors are very radiosensitive, so they cannot really respond to radiotherapy in the always the same way. That means that when the dose needed to control the tumor is much higher than the dose that can damage the normal tissues, of course, the patients will have several complaints. What about prostate cancer? This is an example of a very old radiation field. As you can see, a very simple APPA field, which was not very precise and also was quite large as compared to the fields that we use nowadays. What we are doing nowadays is put fiducials in the prostate, as you can see in this part of the slide, and then we make a CT scan, and then we make a plan, and of course the radiation fields look, as you can see here in green, much smaller than in the previous 100 years. This is an example of the brachytherapy, where the radiation needles or radiation seeds are inserted in the prostate through a template, and this is how a field, or actually a radiation field, looks like. As you can see, is much smaller than the fields like we used many, many years ago. Interestingly, the question is always asked, is there a difference in erectile dysfunction after radiotherapy or after prostatectomy? This is the most important paper published, even if it's older than 10 years ago, showing that immediately after treatment in patients treated by radiotherapy, about 40% of these patients will decrease in their erectile function, and this decrease is much higher after prostatectomy. But this graph also tells you that the patients who get radiotherapy are in general experiencing more erectile dysfunction at baseline before they start with the treatment. But also what is very important is to say that if you look at 5 years, there is actually no difference anymore between radiotherapy and prostatectomy, which is a very important message for your patient. So you might have a patient complaining quite quickly after prostatectomy, but if there is some recovery, of course, the numbers will be much better than as in the beginning. And the mechanism of post-radiation erectile dysfunction is actually not very different in what we see after prostatectomy. It's a multifactorial damage, and this is due to the neuronal damage, but also a muscular damage and a vascular damage. And of course, all these different damages can interact with each other, causing in about 40% of the patients erectile dysfunction in a period of 1 to 3 years. So it seems that this part of the radiation field at the penis, at the base of the penis, might be very important to understand the damage that radiation therapy caused to the neurovascular bundles or to the penile bodies to understand the vascular damage and also neuronal damage. But actually, as we showed already many years ago in this lab experiment, we didn't find actually any correlation between the damage to the crura, the superior most 1 centimeter of the crura, and the penile bulb and the radiation dose. So we couldn't really find a reason why to understand whether the dose to this different part of the penis was correlated to erectile dysfunction. Then, of course, in the years, many techniques, many types of machines, many doses have been used. So starting with 2007, this study looking at the 2 different doses, 68 and 78 gray. And as you can see, this was a randomized clinical trial looking at these 2 dose schedules. And as you can see, after 1 year, about 20 to 25% of the patients complained of erectile dysfunction in both schemes. And this was the same after 2, and this was again the same after 3 years. So actually, the message here is that about 40% of the patients experience erectile dysfunction after radiotherapy for prostate cancer, and it doesn't really matter if you give a dose of 68 or a dose of 78 gray. There have been also more studies showing this. Again, another type of study looking at the conventional dose of 39 times 2 gray as compared to what we call the hypofractionation, so a higher dose per fraction, like in this study, 3.4 gray per fraction, as compared to the normal schedule using the IAIF. This is a randomized clinical trial. You can see that in the 5 domains of the International Index of Erectile Function, there is no difference for erectile function, sexual desire, orgasmic function, overall satisfaction, and intercourse satisfaction between the 2 schedules. So again, the take-home message is it doesn't matter what kind of dose and fraction dose you give to the patients will experience erectile dysfunction in about 40% of the cases, as previously shown. Everybody's asking, of course, the new machines like the CyberKnife. The CyberKnife is a robot machine, and it's a robot that gives us the possibility of giving a very high dose of radiation in a very short time. And to give you an example, with the CyberKnife, you can give 4 fractions of 9.5 gray, which is really very, very high. It's almost 3 times more than you would give with a fraction in a daily situation. And the fields and the planning that we can use and we can make with the CyberKnife can be very precise. But as you can see in this actually small study in about 30 patients, looking in a prospective way and also using the IIEF, they have shown that, again, even in this group of patients with the CyberKnife, about 38% increased, there was an increase in erectile dysfunction as compared to baseline. And that means that, again, about 40% of the patients experience erectile dysfunction, even with these very new techniques. Brachytherapy was introduced to decrease the dose in the rectum and in the bladder, possibly then also in the erectile tissues. And in this study, looking at more than 300 patients with the radiation seats and keeping records of the IIAF-5 questionnaires, as you can see, again, there is a decrease in erectile function in about 2 to 3 years, as you can expect. The number of patients experiencing no erectile dysfunction, about 75% before treatment, go in a period of about 3 years to 25 to 30%. Again, 40% of the patients experience erectile dysfunction also after brachytherapy. And of course, as we can imagine, and this is important also for any kind of radiation used, age and also comorbidities, especially diabetes, vascular diseases like hypertension, ischemic heart disease, are also contributing to the numbers of patients with erectile dysfunction. So the take-home message is that it's important about the age of the patient, it is important about the comorbidity, and of course, it is important about the baseline erectile function of these patients. Protons is by far the most innovative treatment for prostate cancer. Not very common to treat with protons in Europe, prostate cancer, but growing numbers of these patients, but very common in the US, for example. Protons is a very expensive treatment also, and we don't have actually a lot of data on protons and prostate cancer effectiveness, but also on erectile dysfunction after proton therapy. There is one good paper published 6 years ago now in more than 250 patients using the EPIC questionnaires. And as you can see, before treatment, about 80% of the patients complained, didn't complain about erectile dysfunction, of complaint of a normal erectile function, and after about 5 years, that was much less, about 65%. So you could say there is a decrease in the number of patients if treated by protons, but it's important to realize in this specific study that it's just one study, and at 5 years, still 67% of the patients complained of had normal erectile function. And this is a very new, young cohort of patients, all less than 60 years, where you can also expect, of course, that the chance of erectile dysfunction is lower. But it seems less indeed than in the normal fractionation way we have, and we talk about 40% of the patients. About rectal spacers, these have been introduced to create, like here in this graph, you can see some place between the prostate and the rectum. And of course, if you can do this, you can also create more space between the penile bodies, neurovascular bundles, and the prostate. This is not very common, for example, in the Netherlands, but it's well used in some centers like in Europe and especially in the US. Unfortunately, they couldn't find any difference in the erectile dysfunction in these quite small studies with 88 patients, because 70% of the patients maintained erectile dysfunction after 1 year of radiotherapy and 57 after 3 years. But these numbers were exactly the same in the patients with a spacer compared to the patients without a spacer. So it means that it doesn't really help in decreasing. What is more interesting now is the use of the so-called tissue-sparing radiotherapy. This is possible when you delineate the prostate, the neurovascular bundles, the penile bodies on MR. And this was a paper quite recently published on more than 100 patients, a randomized trial. They looked at IMRT-based light on the right side of the slide as compared to the CT-based, and they tried to limit the dose to the penile bodies and the penile bulb, but the IIEF questionnaire didn't show any difference in erectile function in both patients groups. So it doesn't seem that IMRT in an MR-based setting helped that much. Now, recently, the group from Utrecht in the Netherlands is looking at the possibility of decreasing the dose to the neurovascular bundles, and they found in this study with 100 patients and collecting data with the IIEF that technically it is possible to decrease the dose in the penile valve, in the neurovascular bundles in 20% on both sides of the prostate and in almost 70% on one side of the prostate. They didn't use yet they couldn't do any analysis yet on the clinical data. So technically you can spare the neurovascular bundles, but we still don't know whether this will result or not in a decrease in erectile function. The data will follow and the analysis will take some more years. Going to the female pelvic radiotherapy for endometrial and cervical cancer, for those who are not familiar, we have different level of gynecological cancer, from a high-grade carcinoma in situ to, of course, a very extended cervical, in this case, cancer. And of course, another example of an endometrial cancer here, where of course it's important to realize that it's very important to have to understand the stage of the tumor, also realizing that when we treat this cancer, we might need radiotherapy, but also adding even chemotherapy or even hyperthermia, causing, of course, a higher percentage of in this specific case of sexual dysfunction. One of the best papers, even if it's 10 years old, is this paper on the cervical cancer and sexual dysfunction. Here on the right side of the slide, you see an example of a radiation field for external beam and the setting of a cervical brachytherapy with all the needles inserted for locally given radiotherapy. This study looked at 37 patients treated by surgery, 37 treated by radiotherapy, and 40 controls. And they found, of course, a lot of several and different kind of sexual dysfunction: arousability, lubrication, orgasm, sexual satisfaction, overall sexual function. But interestingly and importantly, they showed in this paper that irradiated patients had more complaints as compared to the surgical patients, and of course, as compared to the healthy controls. You can expect that, of course. So actually, the message is that when you give pelvic radiotherapy, the sexual functioning of these patients is worse as compared to those patients where you can do surgery. Unfortunately, you cannot do always surgery for cervical cancer because some of the high-stage disease you cannot treat by surgery because of the very high chance of urological resections. So it's a limited possibility if you cannot do any surgery on them. This is also a very old study, but by far one of the most important studies from Copenhagen, Dr. Jensen, who looked many years ago in a prospective way, longitudinal way, to patients being treated by radiotherapy for cervical cancer. And you can see that in all aspects of sexual function, and you can read yourself this list, there was a statistically significant difference after radiotherapy. So the deterioration was caused in all the aspects, what we expect, dyspareunia, but also in vaginal dimensions, in vaginal lubrication, but also in interest in intimacy and sexual relationship. Very, very important paper that actually has not been done recently with new techniques. What is interesting to look is a sub-study of the EMBRACE, and I'm not going to go into details because it's also a very complicated study, but this study looked at more than 100 patients with cervical cancer, treated with different technique and with different dose, but they did something very innovative, which is getting now to be more and more common, the use of MR-guided brachytherapy, so using a very specific technique of brachytherapy with MR images, but also, very importantly, using counseling on the use of vasodilation to these patients 3 times per week, starting about 4 to 6 weeks after radiotherapy and until 2 years after radiotherapy. And this is really something which is very, very new and not done before in a prospective trial. And what they saw, as you can see, is that actually there is a small decrease. If you will look at these 2 items, has your vagina felt dry during sexual activity, that of course after 6, 12, and 24 months, there are more patients having some complaints, but it's still very, very low numbers. And again, about also dyspareunia is also a little bit increasing after radiotherapy, but actually in a very, very low percentage of cases. So their conclusions was that there is really a mild vaginal change and complaint in this EMBRACE study, and this is probably due to the fact that these patients have been counseled to use vasodilation through the vibrators, but also because of probably the use of an MR-guided brachytherapy that has been really now introduced as a more standard technique in Western countries. And of course, what we also know is the changes that the radiotherapy causes to the vagina. Small number of patients here, 34 patients compared to 37 controls, but they did very interestingly biopsies of vaginal mucosa and also lab tests looking especially at sex steroid levels and also using questionnaires. And you can see they found 90% of the patients with sign of atrophy, 82% with sign of telangiectasia, as you can see here, and the damage and the decrease of the epithelium volume of the vagina was correlated to the sex steroid levels, which also can explain why these patients have less interest in sex, have more local problems, more dyspareunia, vaginal dryness, and of course, sexual complaints in general. And of course, with these specific patients, as I said, many of them will need chemotherapy. And because of chemotherapy and hormonal therapy, they will become, even if they are very young, menopausal, having, of course, weight gain, which is also contributing to loss of attractiveness. But of course, chemo and hormonal therapy per se cause lubrication problems, vaginal bleeding, dyspareunia, loss of sexual desire, less genital sensitivity. These are all additional problems caused by the radiotherapy. So does radiation technique really matter? Yes, for sure, a bit. But what I think is even more important in some cases is the effect of cancer caused directly to the patients with a neural and vessel damage, as I showed, dysfunction caused by the disease and the treatment, but even more important, all the indirect effects of the cancer contributing to depression, fatigue, partnership difficulties, decreased self-image, and these are in some cases even more important than the cancer itself, the direct effect of the cancer itself. So depression, anxiety, anger, already studied many years ago, cause a drop of sexual activity in males and females, and of course also problems in the couples relationships. This is the reason why it is so important when we discuss sexual dysfunction after pelvic radiotherapy, in this specific case, gynecological and prostate cancer patients. We needed to put the patient and the partner at the center of an holistic approach, but an important multi multidisciplinary approach where all together we can contribute to the correct counseling of the patients, but also to the treatment of the patients. Having the medical oncologist, radiation oncologist, mental health expert, together with the nurse, the physiotherapist, psychologists, all these people can help in develop awareness, giving education to the patient, give the right information, and try in this way also to decrease the psychological effects of treatment of cancer. And I come to my take-home messages. Radiotherapy does decrease sexual function in both males and females. Even with the modern techniques that we have, new schedules and new machines, we still impair sexual functioning. Of course, adjuvant treatment like hormonal therapy, chemotherapy also contribute to a decrease in sexual functioning. And we should never forget that sexual functioning is, of course, not only the functioning of the penis in the male, of the vagina in the woman, but it's also, of course, the more psychological and psychosexual aspect, which is important to consider in both the male, female, and their partners. And with this, I want to thank you very much for your attention.
Thank you so much for this great presentation. I don't know if Elena Colonnello wants to say a few words before we move to the next one.
Yes. Thank you everyone for being here, and I'd like to let Armin, my co-chair, to introduce the next speaker. Please, Armin.
So thank you and good evening to everyone. It's my pleasure to introduce our next speaker, Celeste Manfredi, from the University della Campania, Italy. He will give a talk on the role of hyaluronic acid on sexual dysfunction after pelvic radiation therapy. Celeste, the stage is yours.
Thank you so much. So just a few seconds, then we can start with the lecture.
Hello everyone. First of all, I would like to thank the ESSM for the invitation to this webinar. Today we will discuss the use of hyaluronic acid in the management of patients with sexual dysfunction after pelvic radiotherapy. Hyaluronic acid is an anionic non-sulfated glycosaminoglycan. More specifically, it's a polymer of disaccharides which are composed of D-glucuronic acid and N-acetyl D-glucosamine. Depending on the number of repetitions of these disaccharides, it can have different molecular weights. Therefore, we can distinguish hyaluronic acid with high, medium, and low molecular weight. However, there are no standard cutoffs. Hyaluronate synthetases are membrane-bound enzymes which produce hyaluronic acid at the cell surface and extrude it into the extracellular space. On the contrary, hyaluronidases and oxidative damage are the main mechanism involved in degradation of hyaluronic acid. So, hyaluronic acid is an extracellular matrix component. It can be found in all biological tissues in various concentration and molecular sites. It's estimated that there is a total of 15 grams of hyaluronic acid in the human body. Hyaluronic acid is a versatile biomaterial with several applications in biology and medicine due to its favorable characteristics: biocompatibility, biodegradability, non-immunogenicity, and viscoelastic properties. Furthermore, it's associated with several beneficial effects: anti-inflammatory, scavenger, so antioxidant, immune regulation, hydration, lubrification, barrier, tissue regeneration, and wound healing. But it's not all that simple. The biological effects of hyaluronic acid are influenced by its molecular weight. Indeed, hyaluronic acid with high molecular weight has anti-inflammatory, immunosuppressive, and anti-angiogenic effects. In addition, it's highly viscoelastic and viscose. Consequently, it can protect, lubricate the surfaces. On the contrary, hyaluronic acid with lower molecular weight has pro-inflammatory, immunostimulatory, and pro-angiogenic properties. Moreover, it can penetrate more in the tissues. Another key feature of hyaluronic acid is its safety. Side effects are generally uncommon, mild, and self-limiting, sometimes linked to the method of administration rather than the substance. It's rarely allergenic, and there are no significant interactions with other substances. For all these reasons, hyaluronic acid and its derivatives are currently used in many fields of medicine, such as urology, cancer therapy, wound treatment, odontology, aesthetic medicine, and many others. For therapeutic purposes, hyaluronic acid can be produced in vitro, via bacteria, or extracted from animal tissue. To date, this last method is less commonly used due to its complexity and cost. There are many formulations of hyaluronic acid. Indeed, it can be administered in several ways, such as oral, injective, topical, ocular, rectal, nasal, and intravesical. Regarding the oral administration, the absorption capacity of the gastrointestinal tract is quite debated. Indeed, hyaluronic acid is a large polysaccharide that may be degraded in the gastrointestinal tract and therefore not effectively absorbed. Several factors seem to influence the gastrointestinal absorption of hyaluronic acid. First, the molecular weight. Low molecular weight hyaluronic acid is more easily absorbed than high molecular weight hyaluronic acid. Second, the gut microbiota. Bacteria can break down hyaluronic acid into smaller fragments, which may be more easily absorbed. Third, the formulation. Encapsulation enhances bioavailability by protecting hyaluronic acid from stomach degradation and aiding intestinal absorption. And finally, intestinal barrier integrity and intestinal transit time. However, although the absorption of hyaluronic acid taken orally is likely very limited, it has been suggested that distant effects may occur via metabolites or systemic modulation. The effects of radiotherapy on the pelvic organs and its consequences on sexual health have already been discussed in the previous lecture. However, it's useful to point out few essential concepts. The organs at risk with pelvic radiation are genital skin, anus, colorectum, bladder and urethra, prostate and seminal vesicles, testicles, vagina, uterus, nerves and arteries. The main pathophysiological effect of the radiation is the inflammation. Consequently, can arise pain, swelling, erythema, bleeding, fibrosis, anelasticity, stenosis, atrophy, dryness, itching, and functional alterations. Most of these side effects of pelvic radiotherapy can cause worsening of sexual function in both men and women. Therefore, if a treatment reduces the incidence or improves pelvic radiation side effects, it will likely also indirectly improve patient sexual function. However, this remains a reasonable theory in most cases. Indeed, sexual function is often an under-investigated outcome in studies on the prevention and treatment of side effects from pelvic radiotherapy. Hyaluronic acid appears to be a substance that could interrupt the physiopathological mechanism triggered by radiation, leading to improved sexual health. In this context, its anti-inflammatory, barrier, hydrating, and repairing properties may have a key role. This is a randomized controlled trial without placebo, investigating the impact of vaginal suppositories of low molecular weight hyaluronic acid, vitamin A, and vitamin E on the histological and clinical effects induced by adjuvant pelvic radiotherapy for cervical cancer. After 2 months from the end of radiotherapy, the interventional group had significantly less inflammation, cellular atypia, and fibrosis on histological examination, as well as significantly less bleeding, mucositis, and pain at the clinical examination. This is another similar randomized controlled trial without placebo, investigating the impact of vaginal suppositories of low molecular weight hyaluronic acid on symptoms induced by adjuvant pelvic radiotherapy for cervical cancer. At 35 days, treated patients had less severe forms of vaginal dryness, vaginal inflammation, and dyspareunia. Local treatments are widely used against the vaginal toxicity induced by radiotherapy for cervical cancer. This study shows that 60% of the radiotherapists interviewed prescribed a local treatment, and 97% of these suggested hyaluronic acid cream. There are multiple observational studies investigating the use of intravesical distillations of hyaluronic acid for post-radiation cystitis. Most of them included patients with prostate cancer. However, in some articles, there were also some patients with gynecological or colorectal cancers. Overall, intravesical distillation of hyaluronic acid were associated in these studies with improvement in LUTS, reduction in bleeding, and increase in patients' quality of life. This interesting randomized controlled trial without placebo investigated the effects of combining intravesical and oral hyaluronic acid, more specifically hyaluryl prefill and hyaluryl soft gel, in patients undergoing primary radiation therapy for prostate cancer. The authors found that combination therapy compared to control was associated with greater stability and preservation of urinary and global quality of life, according to EPIC score and EQ-5D-5L respectively. Other studies showed that oral administration of hyaluronic acid, more specifically hyaluryl soft gel, alone was associated with reduction in genitourinary toxicity of radiation therapy for prostate cancer. Some studies have also tested hyaluronic acid cream to treat radiodermatitis. In this randomized placebo-controlled trial, hyaluronic acid cream was used in some patients with pelvic tumors treated with radiation therapy. The authors found that patients in the hyaluronic acid cream group had significantly lower skin reaction scores than patients in the placebo group from the 3rd to the 7th week of follow-up. Similarly, the global efficacy evaluation at the end of treatment by both the physician and patient was significantly in favor of hyaluronic acid. Another possible application of hyaluronic acid is as a spacer. It has the purpose of distancing the rectum from the prostate to reduce the rectal volume, receiving a high radiation dose. This can help to reduce potential side effects of radiotherapy. In this randomized controlled trial without placebo, a spacer of hyaluronic acid was tested during the primary radiotherapy for prostate cancer. This spacer of hyaluronic acid was inserted via transperineal approach under transrectal ultrasound guidance. The vast majority of patients in the spacer group experienced a 25% or greater reduction in the rectal volume, receiving 54 grays. In addition, acute grade 2 or higher gastrointestinal toxic effects were significantly more frequent in the control group. Finally, what are take-home messages? The rationale for using hyaluronic acid for the prevention and treatment of side effects from pelvic radiotherapy is strong. Several studies have demonstrated the efficacy and safety of hyaluronic acid in preventing and treating various side effects of pelvic radiotherapy in both men and women. This should theoretically lead to improvement in patients' sexual function. Despite these theoretical assumptions, the evidence directly supporting the use of hyaluronic acid for improving sexual health in patients undergoing pelvic radiotherapy remains very limited. The dosage, routes of administration, and treatment duration of hyaluronic acid in this context have yet to be standardized. Further high-quality studies are needed to strengthen the evidence, standardize therapeutic protocols, and enable scientific societies to issue clear recommendations on this topic. I leave my contacts here in case you have any doubts to clarify after this webinar. Thank you for your attention.
Thank you, Luca. Thank you, Celeste. You gave us a really amazing picture of this topic, which I would say is very, very much underestimated in many patients. I guess we have a lot to discuss. Let's see if they will have any questions from the audience. Not yet, apparently. Daniela?
I can ask a couple of questions, if possible. So
I have
thanks
also a
again.
question, so no problem.
Thanks again, Luca and Celeste, as Elena said, for this fantastic overview. I have a first question for Luca. First of all, it was said since a long time that indeed radiotherapy seems to be in some way safer when compared to surgery, especially for prostate cancer. Indeed, at the end of the day, especially in long-term quality or data, there is no wide difference regarding the sexual outcomes, especially for prostate cancer. Can you comment on this, Luca?
You know, I have always been very honest. And the funny thing is that the urologists in the Netherlands always told me, Luca, you are very honest as a radiation oncologist, because I think that my previous colleagues of previous generation always indeed said that radiotherapies cause less damage. But I think there are a couple of things to say. The first thing is that after radiotherapy, you need to wait at least 2 to 3 years. So if you would ask your patients after 6 months, what you normally do as urologist after radical prostatectomy, no one will complain about erectile dysfunction. So the complaints come really after 1 year, and most of them 2 to 3 years. That's the reason why I think that that paper in New England showing that after radical prostatectomy and radiotherapy, if you wait enough time, you will see really not a big difference. What is true, and this is also the reason why we have to work together with the urologist, is that if the urologist tells you, I can do a radical prostatectomy, but I cannot spare the neurovascular bundles because it's a T3A, of course we are doing better, because we might have 40 to 50% of erectile dysfunction after radiotherapy, but the urologist doing a non-nerve sparing prostatectomy will have 100%. So I have to say that you have really to counsel your patients in the right way. And I'm honest to say that there are cases where we are doing much better as a radiation oncologist, but it's for sure not true that in general, radiotherapy doesn't cause any erectile dysfunction or less erectile dysfunction, because we still see, and I showed with these new techniques, where we were really thinking we will spare the vascular bundles, we would decrease erectile dysfunction, and we don't really see much difference. Still, even with the new techniques, about 40% of our patients will complain. So we have to be honest, and we have to do the good studies with the baseline erectile function, 3 months, 1 year, 2, 3 years, and then you can give a good answer. So it's a little bit a long answer, but just to say that we have to be honest and to look at a scientific way.
Oh, you're totally right. We need to be honest with the patients and take care to the specific cases. So exactly. I have a provocative questions for Celeste. First of all, as you mentioned, the use of hyaluronic acid, there are no very important RCT study, and especially very few studies looking at the sexual function outcomes. So you said that there is good evidence showing that there is an improvement of pain and so on, and probably this can be also the case for sexual function. So I have two provocative questions. The first one is if there are any study using as preventing therapy hyaluronic acid before radiotherapy, I mean. And the second one, if the use of alone hyaluronic acid or a combination of hyaluronic acid and chondroitin sulfate can work better or not.
Thank you for your question, Giovanni. Yes, I think that the most important thing is that this is a topic very, very under-investigated. So this webinar is really important to clarify the evidence on the topic. There are several studies in which hyaluronic acid was tested to prevent the side effects of radiotherapy, but this was specifically related to the cream for the skin reaction. I think that this could be a really interesting topic to attempt to project RCT, because we need to prevent, not to treat, first of all, the sexual dysfunction. About the second question, absolutely yes. Several studies proved that combination of hyaluronic acid and chondroitin sulfate can enhance the beneficial effect, particularly in the context of the radiotherapy. And chondroitin sulfate complements hyaluronic acid properties by providing additional anti-inflammatory and protective effect on the extracellular matrix. So when used together, they can improve tissue hydration, reduce inflammation, enhance tissue repair, and in general leading to a better outcomes in reducing symptoms such as fibrosis, dryness, discomfort, and so probably the sexual dysfunction. So this synergistic effect is why such combinations are often used in formulation aimed to mitigating the radiation side effect. This is my opinion.
May I ask a question, Elena, to Celeste, because I'm very happy, Celeste, that you presented this data, because we don't know that much, and I must say that you radiation oncologists are not even aware of these studies. So also to be a little bit provocative, how would you use hyaluronic acid if you would start a trial for post-radiation erectile dysfunction? And the more practical question is, has it been registered in Europe and reimbursed, or anyway registered by the authorities that it can be used by patients, or it's only maybe the case in some countries and not all of the European countries?
I think that we have now a specific registration for this purpose. I think that the best way is to enhance the available evidence. So, for example, in this moment, the vast majority of the evidence is on the atrophic vaginitis after radiotherapy for cervical cancer, and the post-radiation cystitis for prostate cancer and cervical cancer. So I think that these are the two main fields in which we should center our focus for future research. Improve the research, the evidence that we have today, and then we can project other studies.
Dear colleagues, there's one question from our listeners. Niyanta Yoshi is asking if there is a role of platelet-rich plasma for post-radiation sexual dysfunction. Who likes to comment on that?
Personally, I know that there are few studies on the use of PRP for radiation side effects, because PRP is a search of natural growth factor, and it's be radioprotective by stimulating angiogenesis, epithelialization, but the evidence is very, very, very low. So again, I think that we need first to focus to improve the actual evidence, and then we can attempt to provide other evidence with other substances.
Yeah,
thank you. And then there's another very important question here. So Trajan Roman is asking if this is a general question for all speakers. Do you advise your patients to seek psychological support in order to accommodate to the deterioration of sexual function? This is a very important question. Who likes to comment on that?
If I may start, Celeste, of course. I mean, that's also my point too, that we are all healthcare providers taking care of our patients. So of course, as urologists and oncologists in general, we want to cure the patient, or we want to have the cancer cured. But of course, we always have to think of side effects. So like we are doing in Rotterdam, but I think it's very common in many oncologic clinics, we always have a team, and we always refer the patient who is interested to know more about sexual side effects to a psychologist or urologist specifically, or a sexologist. In Rotterdam, there is a specific situation where I can do both because I'm an oncologist, but also a sexologist. But it's quite common to refer the patient to a psychologist to talk about these aspects, because in many cases, it's not only the damage that we can cause as a radiation oncologist, but it's more the psychosocial effects that the cancer and the treatment can have. So even if they would have a good erection, they would not have a good sexual life just because they are, fear of failure, they are ashamed, they don't have an ejaculation after radiotherapy or even after surgery, and they think, I'm not a male anymore. So these are things that are very important to discuss. So yes, of course, we have to and we should.
I totally agree with Luca. I strongly advise patients undergoing pelvic radiotherapy or radical prostatectomy that the psychological support is essential. I think that this is an essential part of our holistic approach to the patient with a cancer that need of radiotherapy or a surgery.
If I can give more comment regarding the indication. If I'm not wrong, there is a mixed indication or approval among the different countries in Europe, for sure for chronic cystitis, and also in some countries, if I'm not wrong, in Italy, there is also indication for chemio-induced and radio-induced cystitis, for sure. But as you both said and emphasized, we need more evidence. And just to give you an idea, we are working along with the ESSM by collecting all the available data coming from chronic cystitis, from post-radiation cystitis. And also another very interesting issue that we have not discussed this year is the prevention of the recurrent infection. This is another very important topic that can be obviously a possible consequence of radiation cystitis. This is another very important topic, but I totally agree. We need more evidence. There are very few RCT, and also we need more evidence related to sexual function in this specific area. So I completely agree, totally. Any other, Luca, do you want to add something?
No, I see that because it's, it's in the chat and not in the Q&A, but there is someone asking whether there is an effect of oral vitamin C on post-irritation, or I don't know what he means, but I have no data on that. But there might be some data, maybe you can comment, but I am not aware.
For sure, if I'm not wrong, there are some data related, at least for LUTs, for vitamin D, not vitamin C. And another very interesting topic to be addressed, obviously this cannot be the case of prostate cancer, is the use of testosterone, and indeed as an anti-inflammatory effect, because data coming from Mario Maggi labs in people treated with high-FI diet, there is a chronic inflammation within the bladder and within the prostate that can be in some way increased by the hypogonadism and restored by testosterone. So there are several factors probably not taken in the correct level. And there are several, obviously, since a long time, we focused our analysis just for cancer, and that's it. And nowadays, Luca, you have a lot of experience. I think that the quality of life beside the just survey now is a not topic for all the cancer patients.
Completely agree. Good points, Giovanni.
So, Elena, Armin, any other questions from your side? Final remarks?
I think that the multidisciplinary approach in sexual medicine is very important. And the question here, if we all advise our patients to seek also psychological support, as raised by the listeners, is very important. So this is my final remark. Thank you.
Elena?
Yes, absolutely. We had very different specialties participants, like in these webinars, ranging from psychiatric residents to psychologists to urologists and andrologists. So this always remarks us how multidisciplinary is our field, our sexual and health and reproductive field. So I personally believe it's really important to discuss this topic, which are very often underdiagnosed and underestimated. So I thank you again to our speakers to having discussed about all this topic. So I think it's great, and we're looking forward to the next one. Absolutely.
No, for sure. I think that as closing remarks, I think the SSM, and I mean all ISSM family, including ESSM, is the correct family to discuss this issue, and especially are the society that can provide the multidisciplinary approach of all these conditions. But since in people with chronic pain, but essentially the most important symptoms is pain in this case, obviously we need to involve psychologists, we need to include oncologists, we need to include andrologists, and so on, and especially the couple. Luca, you emphasized the male and female part of the coin. Obviously, if there is erectile dysfunction, vaginal dryness, obviously we should, and we must treat the couple, not just one part of the coin. So thank you again, all of you, for joining us for this fantastic talk. Thanks again to IBSA for supporting us. We had a fantastic audience, all part of the world, as always, India, Pakistan, Albania, Ukraine, someone from Israel. So very difficult period for some of affiliated. From the bottom of my heart, I would hope that everything will be fine in a very short time. Thank you. Have a good night. Bye-bye.